we would we would want to actually estimate recruitable collapse and overdistension and talk a little bit of also about the concept of recruitable collapse. So these are two CT scans, two CAT scans of a patient with pneumocystis pneumonia. And this is the same patient at a very, the difference between the two CT scans is a very short time interval, and the big difference in the image is due to differences in PEEP. So this means that there was a lot of collapse here, more than half the lung collapsed, that when the patient was at a low PEEP value, at a higher PEEP value, most of that collapse disappeared. So this is the concept of recruitable collapse. It's a collapse that can go away depending on your PEEP value. So, and why this is important? Of course, collapse has implications in terms of oxygenation, but currently we know that much more than that, collapse is associated with harmful lung ventilation because of the concept of the baby lung proposed by Professor Gattinoni. So if you think of a patient with the lungs that are fully aerated, the patient will have a normal compliance, and the lung will be able to accept a tidal volume that's normal for the patient's size. So which is the tidal volume normalized according to the predicted or ideal body weight. But when you think of a patient with a lot of the lung that's not functioning, has a small functioning lung or baby lung, compliance drops of the respiratory system, and to accommodate a similar tidal volume, driving pressure will be much higher. Transpulmonary pressures and lung strains will be much higher as well. So if you think of the concept that we proposed in the New England paper in 2015, which is the normalization of tidal volume according to the size of the functional lung or the size of the baby lung, we see that this condition will give you a much higher driving pressure. For example, 40 versus H. So this is really why we want to be able to estimate how much recruitable collapse you have according to different PEEP levels, to be able to choose and individualize your PEEP selection for the patient at the bedside. So, and this is where EIT comes in. So EIT, for those of you unfamiliar with the technique, so you just put an electrode belt, this is one part of the belt, around the thorax of the patient, and through this belt, you inject small amounts, tiny electrical currents, alternating electrical currents. As this current traverses or crosses the thorax, it will lead to different tensions or voltages in the surface, and this can be transformed into using a reconstruction algorithm into an image. So the image is something like this. So you get really different shades of blue. The lighter blue indicates more air coming in and out of the lung. The darker blue, less air. And when it's gray, it means it's a silent zone. No air coming in and out, no ventilation to a certain region of the lung. So, for example, if you have a patient with a lot of collapse in the dorsal regions, you might see something like this. So you see that the dorsal regions of the lung in EIT are silent. So that because there's no air coming in and out. So and this is how we first came up with the idea to try to estimate this. So if you can see that these regions are not ventilating at all, for example, this is a swine, a pig with induced ARDS with a PEEP of 10, you see that most of the ventilation goes to the ventral regions and just 20% goes to the dorsal regions. When you change the PEEP level for 15, in this case after a recruitment maneuver, you recover the ventilation to the dorsal regions. So you actually have now two images with very different distributions of ventilation, and we thought that maybe we could use this behavior according to the PEEP level to estimate the amount of recruitable collapse. And that's why we call it actually recruitable collapse, because you have to see a region ventilating, and you need to see that ventilation going away to be able to compare the two. And then you define that the region that I painted here in red is the region that lost ventilation, and thus lost ventilation at a lower PEEP value, thus we call it collapse. So this was proposed in this proof of concept paper back in 2009. And basically what we did is that we did a PEEP titration, decremental PEEP titration curve in a couple of patients. And we drew for each region of the lung, for each pixel value actually, the compliance PEEP curve. But compliance here is not respiratory system compliance, it's regional compliance at the pixel level. So what we observed as a rule was that at very high PEEP levels, compliance is low. As you decrease PEEP levels, compliance increases until it reaches a peak, and then it starts decreasing again. So we compared the behavior with CT scans, in which we identified regions that are overinflated or hyper-aerated. We marked these regions in red. And also here in the dorsal portions, you can see the lung collapse. So, and we did an image of these two situations, and we compared with what we obtained with this algorithm that I will describe to you in further detail shortly. So here we see that there is overdistension in the dorsal region, in the ventral regions. That roughly corresponds to the regions where the red dots appear. And here you see in the collapse image that there is this blue area that roughly corresponds to the dorsal regions in the CT scan. And here I think it's nice to observe that even though there's some spatial correlation, EIT is obviously a technique of low resolution in terms of spatial resolution, even though it has a high temporal resolution and can be used for other purposes or other applications that take advantage of this high spatial resolution, such as perfusion, for example. Okay, so how do we do it? How did we envision or imagine this application of this estimation of recruitable collapse and overdistension? So if you take the pixel compliance PEEP titration curve, remembering it has to be decremental from a higher PEEP to a lower PEEP value, and think of the region to the right after the maximum compliance. It's a region that lost compliance because PEEP values were too low. So from the pathophysiological point of view, the only reasonable explanation for losing aeration or losing ventilation or losing compliance when you decrease PEEP is because either the airway closed or the lung region closed. So we defined this lower collapse, lower compliance at low PEEP levels as compared to the optimal compliance as collapse. So that's the definition of collapse. And likewise, to the left of the maximum PEEP compliance, we have a decreasing compliance because PEEP is too high. So we started at a higher PEEP. As we decrease PEEP, compliance kept increasing and increasing. So the most reasonable explanation for this is that with too high PEEPs, the lung was overdistended. So that's how we defined overdistension in this estimation method. So the nice thing about this is that when we have like a global PEEP, decremental PEEP trial, and you look at compliance, usually it can be very hard to interpret because the lungs can be very heterogeneous. And sometimes you have collapse occurring at one lung region, relief of overdistension occurring at another region, and these two phenomena tend to cancel each other out. So because of EIT, you can actually have one of these curves for every pixel. So imagine you have one pixel in the ventral region, this yellow. So the curve would be something like this. So these regions, they tend to tolerate lower PEEP levels because of they are at in a non-dependent place of the lung. So the transpulmonary pressure, the lung distension itself, is higher. And when you compare to a region that's in the dorsal portion, you'd get something like this. So the maximum compliance would occur at much higher PEEP levels. So from here on, you would get some collapse. So what you can see, actually, think of this X is not, if we thought of it as transpulmonary pressures, what we would get is that this pixel in the ventral region, it has a higher transpulmonary pressure and is thus a little bit overdistended. In this region, on the dorsal part, has lower transpulmonary pressures and can be even collapsed at the same PEEP level. So when we think of transpulmonary pressures, when they're higher than zero, it means the lung region is open. When it's lower than zero, the region is closed. So that's how you can think of it, and that's indeed something very interesting, because when we look at global transpulmonary pressures, we're usually measuring the transpulmonary pressures at the level of the esophagus. So what this means is that when you have a transpulmonary pressure of around 0 to +2, which is numbers that have been used to indicate that the lungs are open, you actually can have a little bit of overdistension at regions above this value, and you can also have a little bit of collapse at regions below. So it's like a compromise between the two, and that's the rationale behind the crossing point PEEP selection that I'll tell you later. Okay, so how does this work in terms this estimation perform in terms of comparison to more classical collapse estimation? So this is a series of experiments we did in pigs comparing collapse measured with EIT and collapse measured with CT. And you can see here that there's a fairly good correspondence between the two. When we do like a scatter plot between the two, there's a nice linear correlation with R-squared values that are fairly good. But there's something that I would like you to pay attention to when you think. So here in the y-axis, there's EIT collapse. On the x-axis, there's the amount of collapse measured by CT. Look at the intercept. So ideally, this intercept would be here, right? 0. When EIT measures 0 collapse, CT also measures 0 collapse, but that's not the case. And the reason is that EIT is actually estimating recruitable collapse. So what this plot indicates is that there was roughly 20% of the lungs that even in the optimal PEEP was still 20% closed. 20% of the lungs was still closed even at the higher PEEP levels. So meaning that part of the collapse that you measure with CT could not be recruited by the pressures that you expose the lungs to. So this is a limitation in a sense of the EIT estimation method. On the other hand, it actually indicates and helps you navigate in the PEEP levels that you are willing to apply to your patients. So you don't, if you're not, let's say this patient only opened this remaining 20% at PEEP levels that would give you plateau levels at around 60 centimeters of water, for example. And you don't want to expose your patient to these high pressures because you're worried that it might have like hemodynamic consequences or barotrauma or whatever. So it means that you don't really have to know that the patient has 20% because you're not willing to expose the patients to PEEP levels that will prevent this collapse from appearing. So it's a kind of a navigation map among the choices, the PEEP choices that you're willing to apply to your patient. So if you think of recruitable collapse, it's more like this. So this is the amount of collapse that EIT estimates and the amount of collapse that CT estimates, taking into account that some residual collapse will occur even at the highest PEEP levels. So this is the tool of this estimation. It can be used in different EIT devices. This is the TIMPEL EIT device. So this is, you could press a PEEP titration right here, and then it'll start recording, assuming that you are already at a high PEEP level. And then it has a counter that when it reaches 0, you can like decrease your PEEP level, and you do that progressively. And let me just fast forward this. So you get like a compliance of the respiratory system here. In blue, you have collapse, and here the image of where the collapse is occurring. So towards the end of the maneuver, so if you stop, then you can get like a history of everything that happened. So you have the compliance curve, the white is the overdistension curve, and the blue is the collapse curve. And most people now use this, what is called the crossing point, which is when collapse and overdistension, they coincide. So this to indicate the PEEP level that you would select at the bedside. So this is the PDF summary that you can download and attach to the medical record after the maneuver is over. So right here you see that there's a crossing point that's roughly around here. So, and you can see like on a tabular format as well, and you have compliance and overdistension, and you can see it would be on the next page where the two of them coincide. So there's a study that was published by the group of Boston, and they showed that there's a very nice coincidence. Not really coincidence, but it's a physiological, it has a physiological reason for that I showed you. So when you think of you have like here collapse, the amount of collapse at decreasing PEEP levels from the right to the left. You see there's no recruitable collapse to start with, and then it starts increasing. And here you see you have the transpulmonary pressures. So there's a good correspondence between the start of increasing collapse and transpulmonary pressures becoming negative. So in this tool has been used in several different scenarios, both experimentally and also in patients clinically. So this is a nice paper that used the estimation of collapse in surgery, patients being submitted to abdominal surgery, to try to individualize the PEEP selection during inside the OR during the surgery. And what they did, this is a small study, randomized study of around 40 patients. And what they did is that they optimized PEEP level according to the EIT PEEP titration tool in one arm. In the other arm, they used a fixed PEEP level of 4, which is the standard practice in the hospital in which the study was conducted. And for the duration of the surgery, right after surgery, patients were extubated and they were taken to the CT scan and to measure the amount of collapse. So these collapse when patients were already extubated. So you see here marked in blue the amount of collapse in a patient from the control group, which during the operation, during surgery, had a collapse of around 49%. And this is a patient in the intervention arm with just a little bit of collapse. And during surgery, the patient only had around 4% of collapse. So these are the CT scans of the patients. And when another interesting aspect is that patients who have collapse, we usually tend to think that, oh, they have collapse because their lungs are sick patients are sick, they have like severe pneumonia, ARDS, or whatever, that's why they collapse. But that's not entirely true. So there are many studies from Professor Jordan Hedin who show that just by laying down in bed and having like sedation and anesthesia induction, you can get a lot of collapse in the dorsal parts of the lung, meaning that it's usually required a certain amount of PEEP to avoid collapse from occurring. So this is something that we have learned in the past couple of years, that when you look at patients with previously normal lungs, which were the patients included in this paper, submitted to abdominal surgery, if you look at the PEEP of the crossing point and you look at body mass index, that there is a certain correlation, meaning that patients with higher body mass index require higher PEEP levels to avoid this collapse. That's because the contents or the weight of the abdomen presses the lung and decreases transpulmonary pressures, favoring the occurrence of collapse. But the nice thing and the interesting thing is that you would expect that these patients or this correlation would change when lungs are sick. So we looked at patients with COVID, and there's also a nice correlation between BMI and the selected PEEP value. But when you plot the two together, you can't really tell apart one from the other. So meaning that the PEEP levels that you would use for a normal lung is not that different from the PEEP level you would use for a sick lung. And most of the, at least a big part of the requirement of PEEP that we will need to avoid collapse is actually related to the body mass index. But then you could say, oh, okay, so wouldn't it be enough, for example, to just know the BMI and then apply PEEP levels that are adequate to a certain BMI? And the answer is clearly no. For example, if you have a BMI of 30, you could have some patients that would need a PEEP value of around 6, other patients that would need a PEEP level of around, let's say, 17. So there's a wide scatter. There's a significant correlation, but a wide scatter around the line. So meaning you really have to individualize or optimize the lung condition if you want to have optimized lung mechanics. Okay. So, and as a consequence of this optimization, you get a gain in terms of driving pressures. So driving pressures, they get lower and lower, especially when patients have larger BMIs. So this experience in very obese patients, I think that maybe the group that's more experienced is the group from Boston. They have this lung rescue team, and they've published this paper in which it's a pre-post paper comparing before the lung rescue team and after the lung rescue team, in which they select and titrate PEEP according to either the transpulmonary pressure with esophageal balloon or with the crossing point using EIT. And they showed, of course, this is observational, hypothesis generating, but they showed that there was a big difference in mortality after they started the lung rescue team. So now I'm going to show you a few papers using the EIT estimation of collapse and overdistension. A couple of them are clinical and one of them is experimental. The first one is the Recruit study that was Glazy, which is the co-first author, is here with us in this webinar. So the recruitment study included over 100 patients with respiratory failure. And this is part of the study in which in patients with COVID. And the idea was to be able to estimate the amount of recruitable lung tissue using EIT. So what they did is they had one increase in PEEP up to 24, and then they would decrease in small steps of 2 centimeters of water and measure the recruitable collapse with the EIT. So in what they, like briefly, what they found is that in terms of the recruitable collapse, which is the difference in collapse from the highest PEEP value to the lowest PEEP value, 24 to 6, was that has had this like wide distribution. And these were COVID patients, right? So there was this people, I've heard many people saying that COVID patients are less recruitable than other patients, but you'll see that it's clearly not the case. So this is the distribution. They divided the recruitability into 3 different categories: low, medium, and high. And you can see that if you compare this to other publications, the amount of recruitment. So this is recruitability from Gattinoni's paper in New England 2006. So this is from Proti, and this is the recruit. So you can see that recruitability is not so different. If it is different at all, it's even higher than previous studies. So by looking at these 3 groups of low, medium, and high recruitability, they could see that there were differences in the PEEP, optimum PEEP selected according to the crossing point. It's really fairly small here. But if you look at the low recruitable patients, they needed less PEEP, was around 10. The medium recruitable patients needed a PEEP of 13, and the high recruiters needed a PEEP of 15, which is the crossing point between the collapse in green and the overdistension in blue. So you see that the low recruiters, they had little collapse, but a lot of overdistension. And as you change to medium and high recruiters, they behave differently. So you see there's a lot of collapse here in green and roughly a similar amount of overdistension. Okay, so 10. So the drop, there was a drop in driving pressure according to recruitability, which was higher in high recruitable patients of around 3 centimeters of water. So if you look at the drop in driving pressures in recruiters was significantly higher than non-recruiters and was here almost 5 centimeters of water. So now I switched to another. So there was this question hanging. So which one is more important, collapse or overdistension? So in the past, we paid much more attention to collapse because we were obsessed with oxygenation. So we thought that maybe the patient should be with lungs that are fully recruited. And I think that ever since 2017, the ART trial, which was which they tried to obtain full lung recruitments using aggressive lung recruitments. So, and actually patients had on average a 20% higher mortality as compared to the control group. So ever since that and other data that came up in the literature. So we know that oxygenation is not really, at least shouldn't be the main goal of the protective mechanical ventilation. So we switched a little bit on gears to focusing and having as a goal an optimized lung mechanical situation, which is much more in line with the concept of optimized driving pressure. So because both collapse and overdistension, both of them actually induce some derangement of lung mechanics, and both of them can force you to apply higher driving pressure. So maybe the best choice is to have a good compromise between the two. So, and this was the first actually paper to try to assess whether having low collapse, low overdistension, or good compromise between the two would be, which of these 3 conditions would be ideal. So this was done by the group of Dr. Burchard. First author is Maison Souza. It was an experimental porcine model in which they included 36 animals, 12 in each arm was randomized. And they did a EIT, decremental PEEP titration maneuver with estimations of lung collapse and lung overdistension in the three groups. And their PEEP choices would be different according to each group. This group would require low collapse, so less than 3% collapse. And as a result, they required on average 15 centimeters of water or PEEP. This group would require less than 3% of overdistension, so they would decrease PEEP to obtain less than 3% of overdistension. So PEEP levels were on average 7. And this is the group in the middle in which they tried to match collapse and overdistension, or the crossing point choice. And what they found is that the group with too low PEEP levels actually had a mortality of around 50%. So mostly because of hemodynamic compromise, because of too low oxygen levels and most likely right heart failure. So, and these other two groups were roughly the same in terms of physiological parameters. So you could stay at a higher PEEP level or at an intermediate PEEP level and have results that are basically the same. Slightly better for the group in the middle. So I'm not going to talk about this meta-analysis, but I just put it here so that you know that there is a meta-analysis on the subject that you could refer to. This is the final paper that I'm going to show you. It's an application of this tool at the bedside. So it occurred during the pandemic. We in our ICU at the University of São Paulo. So we included almost 80 patients, and these patients were randomized to two arms. One arm which followed strictly the ARDSNet network strategy, low PEEP FiO2 table. The other arm had the PEEP selection according to EIT, and also had several maneuvers or a bundle of interventions to try to avoid lung injury and also patient self-inflicted lung injury. So it was a strategy that lasted for the whole mechanical ventilation period. So we only included patients with low respiratory system compliance, which are the patients that are more susceptible or more at risk of lung mechanical of VLI and injurious mechanical ventilation. So basically, we had patients that were patients that were around 60 years of age, and that they were severe with predicted mortalities of around 40 and PF ratios of around 100. So these were like typical COVID patients that would be in our ICUs at the time. So this is a very nice finding of the study. So because every patient before randomization underwent this PEEP selection tool, EIT PEEP selection tool, PEEP titration tool. So all the 76 patients underwent this maneuver. So, but only half of them followed the PEEP selected according to the crossing point. The other half actually followed the PEEP FiO2 table of the ARDSNet. So we could think that because we want to have like an optimized lung condition, so maybe EIT PEEP would always be higher than the PEEP FiO2 table PEEP, but that we saw that was not actually the case. In many instances, the PEEP selecting according to the crossing point was actually lower or equal to the PEEP according to the PEEP FiO2 table. And in the majority, over half of patients actually had a PEEP that was higher if you selected according to the crossing point. But here what you see is that there is no like one simple solution that works for everyone. So the lung mechanics, especially regional lung mechanics, and as a result of lung heterogeneity, that can behave very different. And it's not enough to just look at the oxygenation if you want to really optimize the lung mechanics. So patients were then randomized, and each patient followed the PEEP level that was chosen according to the arm they were randomized to. So this is the result in terms of driving pressure. So driving pressure was on average almost 4 centimeters of water lower in the intervention arm. And this difference, they started very similar. After randomization, they became different, lower in the intervention, and this difference remained fairly stable over time. Same thing happened with compliance. So after randomization, compliance was higher in the intervention arm, and it remained higher, even though it dropped a little bit over time. It dropped in both arms, but the difference remained the same. And this is unheard of after we, like the large versus lower tidal volumes trials, like in the protective era, let's call it this way. So this change in compliance, of this magnitude hasn't really been seen, at least not a sustained change. So if you look at the different trials that have been published, and you look at this trial, which selected people according to EIT and kept it high throughout the ventilation period. So you see that it was a compliance gain that was also maintained. So the primary endpoint was actually a modification of the Murray score. I'll show you that in a moment, but regarding survival, both 28 and 60 days, there was no difference in this trial. There was no difference in terms of time to extubation. There was a difference in terms of the lung function. So oxygenation, patients would get rid of supplemental oxygen faster in the intervention arm as a secondary outcome of this paper. Sorry, I think I erased the slide by accident, but there was the primary outcome of the study actually was a modification of the Murray score, and it was virtually the same at the end of the follow-up period, but the Murray score improved faster in the intervention arm, but it didn't make a difference after when we looked at the 28-day difference. So to like messages to have in mind, so that if you can individualize PEEP. So one way you can do that is by looking at regional lung mechanics and acknowledging that the lungs can be very heterogeneous. And you can minimize both collapse and overdistension by choosing PEEP levels at the crossing point. And there is good agreement with this PEEP choice of the crossing point, with that based on pulmonary pressure using the more invasive esophageal catheter. So thank you very much. I'm now like open for questions.
So thank you very much, Edu. So actually, this was a very insightful presentation, and your expertise on optimization of PEEP and assessing hyperdistension and collapse using electrical impedance tomography has given us a very deep understanding on how EIT actually can be used to fine-tune mechanical ventilation strategies. And now we would like to open the floor for questions. So we know that this topic sparks a lot of interest, and we have already received some questions here. So if you haven't sent your question yet, please now it is the time. So please feel free to submit your question here in the Q&A icon. And as we will go through as many questions as possible. So let's get started here with the first question. And here it's mentioning that there is still some trouble understanding overdistension in EIT. So there is an understanding that the color of the voxel is part of the algorithm, but what is exactly happening in the part of the lung that is marked as overdistended? Too much gas, too much air, or not enough tissue?
But that's a great question, Luis. Uh, and what we are actually measuring there is how far away from the optimal regional compliance we are. So the lungs can become less compliant because they partially collapse. So think of a patient with let's say a patient with a normal compliance of 80 mLs per centimeter of water. So if you remove, like you do a surgery, a pneumonectomy, and take one lung out, so that compliance will roughly become half of what it was before. So compliance is actually that has been shown by Professor Gattinoni using CT scans, that compliance is a very good measure of how much lung you have, like functional lung you have. So that's from the collapse part, which I think is easier to understand. But if you have a PEEP level that's too high, so the lungs can become so distended that their elastic behavior no longer is optimized. So the elastic behavior of the lung becomes less and less efficient. So just as if you like, imagine you have some like rubber band. If you stretch it too much, it will become kind of rigid. So that's the concept of overdistension that's measured by EIT by comparing the compliance, local compliance at a pixel to the optimal compliance that occurs at a lower PEEP value. So because we know that the optimal compliance was at a lower PEEP value, we can conclude that this loss of compliance was because the rubber band was too much stretched. And we've defined that as overdistension. So it's also a continuous measure. It's not overdistended yes or no, like in CT scan. It's a continuous measure of the mechanical derangement. A more precise way would be to call it loss of compliance due to too high PEEPs. How many percent in terms of percentage points, how much compliance did you lose by applying a PEEP that's too high for that pixel? That's what the measurement is. I'm not sure if it was clear for you, Luis, how clear it was.
Okay, thank you, Edu. And now the second question here is, how close is the crossing point PEEP and end expiratory transpulmonary pressure PEEP with esophageal balloon on average?
Oh, that's great, David. So we have a fairly good experience with that, both in animals and in patients. And usually the crossing point matches with the transpulmonary pressure of around +2, which is interesting because if you think, for example, of the post hoc analysis of the AppVent study, you all know that the AppVent 2 study was negative, right? The study that selected PEEP according to the transpulmonary pressures. And just like the AppVent 1 study, in which they targeted a zero transpulmonary pressure, but they also could modify PEEP according to the oxygenation. So the first target was zero, and if oxygenation was too low, you could increase your transpulmonary pressures until you got an oxygenation that was okay. There was a transpulmonary FiO2 table. So they did that in both AppVent 1 and 2, and AppVent 2 was a negative trial. And in this post hoc, it's published in the Blue Journal. In this post hoc paper, they saw that actually, if you compared patients around zero from -2 to +2, in terms of clinical hard outcomes, they fared better as compared to patients in the extremes with too low transpulmonary pressure or too high transpulmonary pressures. So this means that probably a good target is around zero, probably more towards the +2. And the crossing point tends to coincide with the +2 transpulmonary pressures. There's the trial that's begun. in BI, in that Israel hospital, it's multi-center. They're now trying, it's called Prevent trial, and they're recruiting patients. They're trying to see if a strategy that targets a transpulmonary pressure of around 0 is better. And they won't look into oxygenation in this study. They will really try to target the transpulmonary pressures. So which would be somewhat equivalent to targeting the crossing point if you use a different method of titration. Neto, I cannot hear you. Neto, cannot hear you.
Sorry, I was muted here. So we have a
Okay.
next question here. So do you check for recruitability before sending the PEEP with EIT, or you apply it to all your patients in the ICU and look to the crossing point and overdistension? Because you mentioned that the trials that only 20 to 30% of the patients are recruitable.
Okay, that's a great question actually, and I wish we had a way to find out if the patient is recruitable or not without trying to recruit. But we haven't, we don't have that answer. At least we don't have it yet. So what we do on what I do in my practice is that if I think if that the patient is not protected, driving pressures, for example, are too high, respiratory rates are too high, or if the patients are too hypoxemic, even after doing everything that should be done for hypoxemia, I try to recruit the patients. I no longer do the full recruitment. After the ART trial, we do a more gentle recruitment maneuver, and after this recruitment maneuver, we do the decremental PEEP titration. So that's how I do it. But irrespective of whether you want to recruit or not, you just have to increase PEEP to the PEEP that you are clinically willing to apply and go from there down. And choose the PEEP level that's optimal within that range. So basically that's why I wanted to emphasize that what we are really measuring is the recruitable collapse. So it's the collapse that's added on top of what you had before. So just to summarize, I do a recruitment maneuver with plateau pressures that are around 45 to 50, and then PEEP titration starting from PEEP levels at around 24 to 25. And we decrease on 2 centimeters of water steps until low PEEP levels and choose the crossing point.
Good, very good. So the next question here, is there a minimum PEEP level that is typically used as a starting point for PEEP titration?
Good point. So I think it also depends. Usually, like classically, we use PEEP levels of around 24, 25, because based on previous CT scan studies, we know that these PEEP levels are usually enough for most patients to maintain open whatever region you opened before if you perform the recruitment maneuver. So typically your PEEP levels, it's hard to have a PEEP level that's higher than that. So that's the rationale behind that choice. But that can be it's often enough, but it can be insufficient if, for example, you have patients that have BMIs that are too high. So patients with BMIs that are above 35, 40, sometimes you need higher PEEP levels, and thus your PEEP titration maneuver should start at higher PEEP levels to account for that. And it's nice because those patients, they have because of their high BMIs, they have large positive pleural pressures. Their transpulmonary pressures are not that high, and they tolerate very well these high PEEP levels, because usually the lungs are not overdistended even at high PEEP levels, because it's PEEPs being used just to compensate for the weight of the abdomen. So In summary, usually 24, 25. Sometimes if the patient has a lot of, if the BMI is too high, the patients with obesity, you can choose higher PEEP levels. One hint, if you allow me, let's say you don't want to expose your patient like upfront to a PEEP level above 24, 25. But if during the first steps you already see collapse, like from 24 to 22, you already see collapse, and 22 to 20, so that's most likely you were not at an optimal PEEP to start with. Usually collapse comes after at least a few steps.
Okay, thank you, Edu. Now I think that we are coming to the last questions here. So the next one is, in patients on assisted or spontaneous ventilation, accurately measuring respiratory system compliance can be quite challenging. So given this limitation, what strategies can be used to properly set PEEP in order to prevent both lung overdistension and collapse in these conditions?
Oh, that's a very good and very tricky question. So indeed, I would say it's if you're being like rigid and strict, it's virtually impossible to be able to actually measure collapse and overdistension if the patient is breathing spontaneously with an assisted mode, for example. There have been some attempts. Professor Mauri from Italy, for example, has used the same tool that we discussed today, the PEEP estimation tool, using also information that comes from the esophageal balloon. So he was trying to estimate collapse and overdistension by taking into account how much effort the patient is doing. So that's one way to go, but I think very it's very unlikely that becomes clinically used because of the complexity of having esophageal balloon and also EIT and et cetera, et cetera. So there's perhaps one much more appealing and much easier way, even though it's not really an estimation of collapse or overdistension, but you can look at the EIT phenotypes. So we know that, for example, if the patient is very overdistended, it usually tends to occur in the ventral regions. So if you have a ventilation distribution that's more than 60% to the dorsal regions, most likely you have overdistension. So that's an indication of too high PEEP. So there's a nice paper from Professor Yoshida and Professor Brocha in the Blue Journal showing that that was the case. EIT was used to lower the PEEP value in a patient that was recovering. Conversely, you can have distribution of ventilation that's too low in the dorsal regions. Let's say you have 20% of the ventilation going to the dorsal regions. That would be an indication of silent zones in the dorsal region and perhaps too low PEEP. You can tell for sure that that dorsal silent space will be recruitable. So you'd have to check by increasing PEEP and looking at what happened to the amount of ventilation that goes to the dorsal region. So, but really estimating in spontaneously breathing patients, I don't know of a way to precisely do that.
Okay, we'll have two more questions here. So first, what is the impact of tidal recruitment on the PEEP titration results?
That's a great one. And actually, I think we should study that in detail. We have I have a conceptual model of how tidal recruitment would impact on these estimates. And and that's that's actually the reason why we advocate that healthcare professionals, respiratory therapists, and physicians that do the PEEP titration maneuver with EIT use very low tidal volumes during the maneuver, 6 or even 5 mLs per kilogram, to try to avoid tidal recruitment. What happens with tidal recruitment is that your lung compliance as a whole, like the global lung compliance and even the regional lung compliance, they will appear very high when it's actually a result of lungs or lung regions that are completely collapsing and reopening during a breath. So the movement of air is actually more than the movement that you would get at a normal breath, because the air of the alveoli wouldn't be entirely exhaled if there was no tidal recruitment. So it's a classical scenario in which there's overestimation of lung compliance, both globally and regionally. So you would get lower selected PEEP values because the lung, let's say the lung is already collapsing at the end of expiration, but it's opening back up during inspiration. So you will get a very good compliance, but that's fake. That's not really compliance. That's tidal recruitment. So you will think that that PEEP level is okay, but it's not. So if you had lower tidal volumes, the lungs would collapse and stay collapsed, and that would be reflected on a lower compliance, and you would be able to realize that there was already some collapse going on. So, but I think that to tell you the truth, I think that that needs to be studied in further detail to be able to tell how much of an effect there is of selecting different tidal volumes. There's one paper that I know of, but I think that it didn't answer the question like entirely.
Thank you very much, Dr. Eduardo. I think we are coming to the end of this session here. So first of all, I want to give you a huge thank to your participation, for sharing your expertise with us, and all of you that join us today for your participation and engagement. It's been a fantastic discussion here today, and we hope all of you found it really valuable. And this session is the first one, and we are just in the beginning. So our next session for TIMPEL On Air will take place on April 9, where we will dive deep into a very interesting topic that is detecting asynchronous with EIT insights. So I would like to invite all of you to register to our next session. I'm not sure if you can see my screen here.
Yeah.
Yeah, so please, you can scan the QR code and you can join us. You can register to receive some news about our next session. So we are announcing, it's the first announcement for our next session. So thank you everyone again. Thank you everyone once again for being here with us. It was really valuable to have all of you with us today. And thank you again, Eduardo, for taking your time, all of you to taking your time to join us today. And stay tuned. So please, you can subscribe to our YouTube channel. You can follow us on our LinkedIn page to stay tuned about our next activities here. So once again, thank you all for being here today, and we look forward to seeing you on April 9. And I hope all of you have a great day. Thank you very much, and see you soon.
Thank you, Neto. It was a pleasure. Thank you all for your attention and for the very nice questions. It was my pleasure.
Thank you very much. Bye-bye, and see you soon.